is pathogenesis and pathology of AIDS or acquired immunodeficiency syndrome. AIDS is caused by HIV. It is a retrovirus human immunodeficiency virus characterized by profound immunosuppression that leads to opportunistic infections, secondary neoplasm, and neurological manifestations. It is a most dangerous virus in our world. Three major routes of transmission: sexual contact, parenteral inoculation, passage of the virus from infected mothers to their newborns. Sexual transmission is the dominant mode of infection. Near about 75% of all cases of HIV transmission. Because of the majority of infected people in the United States are men who have sex with men, most sexual transmission has occurred among homosexual men. The virus is carried in the semen and it enters the recipient body through abrasion in rectal or oral mucosa or by direct contact with mucosal lining cells. Viral transmission occurs in two ways: direct inoculation into the blood vessels breached by trauma, and second is infection of dendritic cell or CD4 cell within the mucosa. Parenteral transmission of HIV has occurred in three groups of individuals. Most importantly, intravenous drug abusers or users, hemophiliacs who received factor 8 or factor 9, random recipient of blood transfusion. Of these three, intravenous drug abuser is by far the largest group. Second is mother-to-infant transmission, is the major cause of pediatric AIDS. How it occurs? In utero by transplacental spread, during delivery through an infected birth canal, and after birth by ingestion of breast milk. Of this, transmission during birth, that is called intrapartum, and in the immediate period thereafter, that is called peripartum, is considered to be the most common mode in the United States. Higher risk of transmission is associated with high maternal viral load and low CD4 plus T cell count, as well as poliomyelitis. Fortunately, antiretroviral therapy or ART given to infected pregnant women in the United States has virtually eliminated mother-to-child transmission, but it remains a major source of infection in areas where this treatment is not available. Now, etiology, the properties of HIV. HIV is a human retrovirus belonging to lentivirus family. It is two types, HIV-1 and HIV-2. HIV-1 is the most common type associated with AIDS in the United States, Europe, and Central Africa. In India, HIV-2 is common. Specific tests for HIV-2 are available, and blood collected for transfusion is routine screened for both HIV-1 and HIV-2 seropositivity. Now, the structure of HIV. Similar to most retrovirus, HIV-1 variant is spherical and contains an electron dense cone-shaped pore surrounded by a lipid envelope derived from the host cell membrane. It contains major capsid protein 24. It is the most important protein, major capsid protein P24. Then nucleocapsid protein P7, P9, 2 copies of viral genomic RNA, and 3 viral enzymes, protease, reverse transcriptase, and integrase. P24 is the most abundant viral antigen and is detected by an ELISA that is widely used to diagnose HIV infection. The viral core is surrounded by a matrix protein called P17. And there are two important glycoproteins that is called GP120 and GP41. These are the most important glycoprotein and I can say most important structure of HIV virus, GP120 and GP41. And HIV-1 RNA genome contains GAC, pol, ENV genes. This is the structure of HIV virus. This is GP120, this is GP41. This is P17 matrix, this is P24 capsid. And this is the reverse transcriptase enzyme. Normally what happens? Normally from DNA to RNA, from RNA protein, normally. But in case of HIV, this is not happening. What is happening? Here, from RNA to DNA, then DNA to mRNA protein. And from mRNA protein, a new virus is created. So how RNA, one RNA virus is converted to DNA virus? It is a special virus. I told you it is a special virus because RNA to DNA happen here by reverse transcriptase enzyme. As it is a very special virus, it carries this reverse transcriptase enzyme with its own structure. This reverse transcriptase enzyme carried by HIV virus. That's why it can convert from RNA to DNA, from DNA to mRNA, from mRNA a new virus. And with the help of this GP120 protein, this GP120, it gets attached with the host cell. And it is a bilayer. It is a bilayer, lipid bilayer. So one layer of its own and the another layer from where the another layer is coming. This virus from host cell. That's why it is called lipid bilayer. Now pathogenesis. Although HIV can infect many tissue, major target is immune system. This HIV virus is the only virus that can infect T cell, B cell, microglia, CD4 plus helper T cell, the whole and macrophages. The whole immune system this HIV virus can infect. যেটা অন্য কোনো ভাইরাস পারে না। Profound immune deficiency, primarily affecting cell-mediated immunity, is the hallmark of AIDS. That's why profound immunodeficiency is occurring because it infects T cell, B cell, macrophages, glial cell, monocyte, everything. একটা ইমিউন সিস্টেমে যতগুলো সেল থাকে HIV virus can infect all. That's why profound immunodeficiency is occurring here. HIV enters the body through mucosal tissue and blood and first infects T cell as well as dendritic cell and macrophages. The infection becomes established in lymphatic tissue where the virus may remain latent for long periods. Now the life cycle, infection of cell, integration of provirus into host cell genome, activation of viral replication, and production of release of infectious virus. First is infection of cell by HIV. HIV infects cell by using the CD4 molecule as a receptor and various chemokine receptor as co-receptor. Chemokine receptor, as I told previously, it can infect CD4 plus T cell, helper T cell, and macrophages. There are some chemokine receptors like CCR5, CXCR4. These two chemokine receptors is there. CCR5 present in the macrophages and CXCR4 present in the T helper cell. And it can also infect monocyte macrophage system. Binding to CD4 is not sufficient for infection. HIV GP120 must also bind to other cell surface molecule that is co-receptor for entry into the cell. Chemokine receptor CCR5 and CXCR4. CCR5 present in the macrophages and CXCR4 present in the a T helper cell. And there are few CD4 positive cells, like one is T helper cell, another is monocyte, then macrophages, glial cell present in CNS. The name of that cell? Macrophages present in the CNS. What is the name of that macrophages? A special name is there. Microglial cell. So these are CD4 positive cell. So as it is CD4 positive cell, so HIV infects all these cells. CD4 helper cell, monocyte, macrophage, microglial cell, all. In approximately, there is a strain, R5 strain preferentially infects cells of the monocyte macrophage lineage and thus referred to as M-tropic. In approximately 90% of cases, the R5 type of HIV is the dominant virus. Molecular details of deadly handshake between HIV glycoprotein and their cell surface receptor have been elucidated and are important to understand because they may provide the basis for additional HIV therapy. That's why it is important. I told you earlier that GP120 is important. Why? Why GP120 is important? Because of there are some drugs who can affect on the GP120 molecule. The initial step in infection is the binding of GP120 envelope glycoprotein to CD4, which leads to a conformational change that produces new recognition site of GP120 for the co-receptor CCR5 or CXCR4. So first, HIV virus got attached to the CD4 helper T cell. After that, when it comes to the CXCR4 or CCR5, then there are some conformational change occur, and due to this conformational change, virus get incorporated inside the host cell, and after that, a lipid bilayer membrane is forming after entering into the host cell. So if it is macrophage, it will bind with CCR5. If it is a T helper cell, then it will bind with CXCR4. And there are some drugs, if they can block this chemokine receptor, I mean CCR5 or CXCR4, like Maravirac. It is a drug which unblock this CCR5 or CXCR4. If it is blocked, then HIV virus cannot bind with host cell. So binding to the co-receptor induces conformational change in GP41 that result in hydrophobic region called fusion peptide at the tip of GP41. And after that, leading to fusion of the virus and the host cell membrane. After that fusion, virus enter into the host cell. The requirement of HIV binding to co-receptor may have important implication for pathogenesis of AIDS. Now viral replication. Once internalized, the RNA genome of the virus undergoes reverse transcription, leading to synthesis of double-stranded complementary DNA. I told you earlier, it is an RNA virus. Inside the cell, it becomes DNA virus because of it carries reverse transcriptase. HIV infects memory and activated T cell, but is inefficient at productively infective naked T cell. Completion of the viral life cycle in latently infected cell occur only after cell activation, and in the case of most CD4 plus T cell, viral replication and shedding result in cell lysis. This is the life cycle. First, this is the virus, then GP120 CD4 binding, then conformational change occur, then GP120 CD4 bind CCR5, then the virus enter into the host cell, HIV RNA genome. With this RNA attach reverse transcriptase enzyme, then it becomes DNA, then after that a new virus, a new protein synthesis, and new virus forms occurring. Now, mechanism of T cell depletion in HIV infection. Loss of infected CD4 plus T cell is mainly because of the direct cytopathic effects of the replicating virus. Can you tell me in this time how many people are living with HIV? That is called PLHIV. People living with HIV means they are carrying HIV virus on their body, but symptoms may have symptoms or may not be, may be asymptomatic. The number is approximately 33 million people in the world are PLHIV or people living with HIV. 33 million. And among them, how many people die every year with HIV virus? It is almost 2 million. 2 million people die every year due to HIV. Because of the frequency infected cells in the circulation is very low, for many years it was suspected that the immunodeficiency is out of proportion to the level of infection and cannot be attributed to death of the infected cells. Up to a point of immune system can replace the dying T cells, and hence the rate of T cell loss may appear deceptively low, but as the disease progresses, renewal of CD4 T cell cannot keep up with their loss. Up to a portion, new CD4 T cell will come in your circulation, but it will up to a level. After crossing the level of T cell depletion, our body cannot replace. New T cell will not replace. In addition to direct killing of the cell by virus, other mechanisms may contribute to the loss of T cell. Chronic activation of uninfected cells responding to HIV itself or to infections that are common in individuals with AIDS lead to apoptosis of the cell by process of activation-induced cell death. And there is inflammasome pathway is there and lead to form of cell death that has been called pyroptosis. During this process, inflammatory cytokine and cellular content are released, thus potentiate recruitment of new cells and increasing the number of cells that can be infected. HIV infects cells in secondary lymphoid organ like spleen, lymph node, tonsil may cause progressive destruction of the architecture. Loss of immature precursor of CD4 plus T cell can also occur either by direct infection of thymic progenitor cell or by infection of accessory cell. Although marked regression of CD4 plus T cell, a hallmark of AIDS can account for most of the immunodeficiency late in the course of HIV infection. Low-level chronic or latent infection of T cell is an important feature of HIV infection. It is basically low-level infection. এমন নয় যে HIV ভাইরাস বডিতে এন্টার করলো আর খুব হাই লেভেল ইনফেকশন হলো। মোস্ট অফ দ্য কেসে it is a low-level infection. And that's why people carrying HIV virus, they are asymptomatic. Even with potent antiviral therapy, which practically sterilizes the peripheral blood, latent virus lurks with the CD4 cell, both T cell and macrophage, in the lymph nodes. So that HIV virus enters into the macrophage and it stored there. Because of most of these CD4 plus T cell are memory cell, they are long-lived with a lifespan of months to years and thus provide a persistent reservoir of virus. CD4 plus T cell plays a pivotal role in regulation both cellular and humoral immune responses. Therefore, loss of this master regulator has ripple effect on virtually every other component of immune system. Because CD4 plus T cell is the most important cell in the immune system. আমি পড়িয়েছিলাম যখন immunity আমি পড়িয়েছিলাম তখন বলেছিলাম the CD4 plus T cell is the master regulator of our immune system. So major abnormality of immune function in AIDS: lymphopenia, decreased T cell function, altered T cell function, polyclonal B cell activation, altered monocyte or macrophage function. These are the major abnormality of immune function occurring in HIV. Now, HIV infection of non-T cell. Non-T cell means dendritic cell and macrophages. These are the two most important cells which affected by HIV virus. The number of macrophages infected by HIV in the tissue greatly exceeds the number of infected blood monocytes. In certain tissues such as lung and brain, as many as 10 to 50% macrophages are infected. Basically, কি হয় না HIV virus enter করে, if it is entering the macrophage, it gets stored for many years. এবং ওই macrophage থেকে ও মাঝে মাঝে intermittently ও infect করে বাকিকে. Although cell division is required for nuclear entry and replication of most retrovirus, HIV-1 can infect and multiply in terminally differentiated non-dividing macrophages. This property of HIV-1 dependent on the viral VPR gene. Infected macrophages bug relatively small amount of virus from the cell surface, but this cell contain large number of virus particles. Even though macrophages allow viral replication, they are quite resistant to the cytopathic effect of HIV in contrast to CD4 T cell. Thus, in next stage of HIV infection, when CD4 T cell number decline greatly, macrophage may be an important site of continued viral replication and reservoir of viral persistence. Macrophage may act as portal of infection because in more than 90% of cases, acute HIV infection is by M-tropic strain. These defects include impaired microbicidal activity, decreased chemotaxis, decreased secretion of IL-1, inappropriate secretion of TNF, and poor capacity of present antigen to T cell. Also, infected monocyte may carry HIV from blood to various parts of body, including the nervous system, where infiltrated infected monocyte may be a source of virus. Now, B cell function. I told you previously, dendritic cell, mature dendritic cell, act as antigen presenting cell. Antigen presenting cell in immunity. So HIV virus infect that antigen presenting cell also. ও সবাইকে ইনফেক্ট করে দিচ্ছে, CD4 T সেলকে ইনফেক্ট করছে, T হেল্পার সেলকে ইনফেক্ট করছে, ম্যাক্রোফেজকেও ইনফেক্ট করে দিচ্ছে, তার ফলে অ্যান্টিজেন এবং ডেনড্রাইটিস সেলকেও ইনফেক্ট করছে, দ্যাট ইজ অ্যান্টিজেন প্রেজেন্টিং সেল। ওটাও যদি ইনফেক্টেড হয়ে যায় তাহলে আমাদের যে ইমিউন সিস্টেম সেটা টোটালি ডিস্ট্রয় হয়ে যাবে। Now, B cell function in HIV infection. Although HIV infect T cell, macrophage, dendritic cell, it can also infect B cell also. Paradoxically, early in this disease, there is polyclonal activation of B cell, resulting in germinal center B cell hyperplasia, sometimes accompanied by autoimmune phenomena like immune thrombocytic purpura or ITP. B cell activation may result from multiple mechanisms, reactivation or reinfection with EBV or Epstein-Barr virus, or in short it is called EBV, which is a polyclonal B cell activator, viral GP41, which can promote B cell growth and differentiation, increase production of IL-6, which stimulate proliferation of B cell by HIV infected macrophages. And here plasma cell also increase in the number, so leading to hyper gamma globulinemia and bone marrow plasma cytosis. Now, pathogenesis of CNS, pathogenesis of CNS by infected microglial cell. Microglial cell is also infected because it is also a CD4 positive cell. And syndrome is called HIV-associated neurocognitive disorder, or HAND, because of infected microglial cell. The mechanism of HIV-induced damage of brain remain obscure because neurons are not infected by HIV and the extent of neuropathology changes is less than might be expected from the severity of neurologic symptom, but it may be due to indirectly by viral product and by soluble factor produced by infected microglia. So here the main culprit is IL-1, TNF, IL-6. In addition, GP41. Direct damage of neuron by soluble HIV GP120 has been postulated. Natural history of HIV infection. Virus typically enter through mucosal epithelia. First is an acute retroviral syndrome. Second is a middle chronic phase. Then third is clinical AIDS. Primary infection, virus dissemination, and acute retroviral syndrome. Acute infection of memory CD4 plus T cell, which express CCR5 in mucosal lymphoid tissue. Because the mucosal tissue are the largest reservoir of memory T cell in the body, and memory T cell are susceptible to HIV infection, and thus by decreasing the number of lymphocytes. Then mucosal infection occur, mucosal infection followed by dissemination of the virus. Dendritic cell in epithelia at site of virus entry capture the virus and then migrate into the lymph node. Once in lymphoid tissue, dendritic cell may pass HIV onto CD4 plus T cell through direct cell-to-cell contact. This replication leads to viremia, during which high number of HIV particles present in patient's blood. The virus disseminates throughout the body and infect helper T cell, macrophages, dendritic cell in peripheral lymphoid tissue. As the HIV infection spread, individual mount antiviral humoral and cell-mediated immune response. This response leads to seroconversion and the development of virus-specific CD8 plus cytotoxic T cell. HIV-specific CD8 plus T cell detected in blood at about the time of viral titer begin to fall, most likely responsible for initial containment of HIV infection. কারণ আমি যখন পড়িয়েছিলাম ইমিউনিটি তখন আমি বলেছিলাম যে CD8 T cell কি করে CD8 plus T cell অ্যান্টিভাইরাল ও ভাইরাল এফেক্টেড সেলকে ভাইরাস এফেক্টেড সেলকে ও কিল করে তাহলে CD8 plus T cell এটাই করবে This immune response partially controls the infection and viral protection as reflected by drop in viremia to low. কিন্তু ও পুরোপুরি পারে না CD8 plus T cell পুরোপুরি HIV ভাইরাসকে কন্ট্রোল করতে পারে না একটা লেভেল অবধিও পারে Now the acute retroviral syndrome is the clinical presentation of the initial spread of the virus. This typically occurs 3 to 6 weeks after infection and resolves spontaneously in 2 to 4 weeks. Symptoms are sore throat, myalgia, fever, weight loss, and fatigue, and sometimes rash. The level of HIV-1 RNA in the blood is a useful marker of HIV disease progression and is of clinical value in the management of people in HIV infection. So viral load detect করবো আমরা HIV-1 RNA দিয়ে So because of loss of immune containment associated with declining CD4 plus T cell count, we can divide it in 3 parts. CD4 plus T cell greater than or equal to 500 cells per microliter, 200 to 499 cells per microliter, and fewer than 200 cells per microliter. It is a classification given by CDC, asymptomatic, symptomatic, AIDS indicator conditions. It depends on by CD4 plus T cell more than 500, 200 to 499, and less than 200. For clinical management, the blood CD4 T cell count is perhaps the most reliable short-term indicator of disease progression. For this reason, CD4 cell count is the primary clinical measurement used to determine when to start antiretroviral therapy. অ্যান্টিরেট্রোভাইরাল থেরাপি দেওয়ার সময় CD4 প্লাস T সেলটাই মনিটর করা হয়, নট HIV-1 RNA। It is CD4 plus T cell. CD4 plus T cell count দেখেই ART দেওয়া হয়। Now chronic infection, phase of clinical latency. Chronic phase of the disease. During this period of disease, few or no clinical manifestation of the HIV infection are present. Therefore, this is called clinical latency period. Although the majority of peripheral blood T cells do not harbor the virus, destruction of CD4 plus T cell within lymphoid tissue continues, and the number of CD4 plus T cell in the blood steadily decline. Destruction of CD4 plus T cell that are critical for effective immunity, antigenic variation, and down modulation of class 1 MHC molecule on infected cell so that viral antigen are not recognized by CD8 plus T cell. During this period, the virus may evolve and switch from relying solely on CCR5 to enter its target cell on either CXCR4 or both CCR5 or CXCR4. This co-receptor switch means CCR5 and CXCR4. আমি বললাম প্রথমে যেটা আমি বলেছিলাম CCR5 present in macrophages, CXCR4 present in T helper cell, but it and switch, that is called co-receptor switch. CXCR4 হতে পারে, CXCR4 হতে পারে, আবার CCR5 হতে পারে। এই co-receptor switch unique property of HIV virus. And another is the switching of down modulation of class 1 molecule, that is switching. So it is not easy for CD8 molecule. There are some in chronic phase of infection, patient may be either asymptomatic or develop minor opportunistic infections such as oral candidiasis, vaginal candidiasis, herpes zoster, perhaps tuberculosis. Now AIDS. Final phase of progression is AIDS. Breakdown of host defense, dramatic increase in viral load, and severe life-threatening clinical disease. Symptoms are long-lasting fever more than 1 month, fatigue, weight loss, diarrhea, generalized lymph node enlargement, fever, weight loss, diarrhea, generalized lymphadenopathy, multiple opportunistic infection, neurological disease, and secondary neoplasm. Opportunistic infections. These are the opportunistic infections. Some important are Candida, cytomegalovirus, atypical and typical mycobacteria, Cryptococcus neoformans, Toxoplasma gondii, Cryptosporidium, herpes simplex virus, papillomavirus, and Histoplasma capsulatum. There are lots of opportunistic infection occurs in a patient of AIDS. And most importantly, it can cause neoplasm, that is called cancer. Which cancer? Kaposi sarcoma, primary lymphoma of brain, invasive cancer of uterine cervix. Kaposi sarcoma, cervical cancer in women, anal cancer in men. Caused by oncogenic DNA virus, specifically human herpes virus 8, KS, EBV, that is called Epstein-Barr virus, that causes B-cell lymphoma, and human papilloma virus, cervical and anal carcinoma. Kaposi sarcoma, it is basically a vascular tumor characterized by proliferation of spindle-shaped cells that express marker of both endothelial cell and smooth muscle cell. Caused by human herpes virus 8, also called KSHV, Kaposi sarcoma herpes virus. Lymphoma. Why lymphoma occur in HIV AIDS? Because of unchecked proliferation of B cell infected with oncogenic herpes virus in the setting of profound T cell depletion, T cell immunity is required to restrain the proliferation of B cell infected with oncogenic viruses such as Epstein-Barr virus and HHV-8. With the appearance of severe T cell depletion, this control is lost. কি হয় না T cell depletion হচ্ছে T cell depletion হলে কি হবে T cell depletion হলে B cell বাড়বে না germinal center B cell এর germinal center hyperplasia হবে. Patients with AIDS are high level of several cytokines, some of which including IL-6 growth factor for B cell. These patients are also chronically infected with pathogens that may lead to B cell stimulation. In the absence of T cell immunity, these activated EBV infected clones proliferate and outgrowth full-blown EBV positive B cell lymphoma. So this is the mechanism. Early infection, advanced infection. Early infection increase follicular T helper cell. Now, while this number is increasing, follicular T helper cell, that we don't know. But দেখা যাচ্ছে যে early infection এ follicular T helper cellটা increase হয়. কেন হয় জানা নেই. তখন কি হচ্ছে জার্মিনাল সেন্টার বি সেল হাইপারপ্লেসিয়া হচ্ছে যার ফলে বি সেল লিম্ফোমা বার্হিক লিম্ফোমা and large B cell lymphoma হচ্ছে. And another thing occurring, disease progression, advanced infection, তখন T cell depletion হচ্ছে. T cell depletion হওয়ার ফলে unchecked Epstein-Barr virus reactivation হচ্ছে latently infected B cells. ও বি সেলটাকে ইনফেক্ট করে দিচ্ছে যেহেতু টি সেল ডিপ্লেটেড বি সেল জার্মিনাল হাইপারপ্লেসিয়া হবে তার ফলে ইবিভি পজিটিভ লার্জ সেল লিম্ফোমা HHV-8 পজিটিভ প্রাইমারি ইফিউশন লিম্ফোমা সো দেয়ার আর টু মেকানিজম অফ ক্যান্সার ইন HIV. One is germinal center B cell hyperplasia, another is unchecked EBV or KSHV reactivation of latently infected B cell. So there are two mechanisms. Lymphoma occurring in HIV. বুঝতে পারলাম?